Awesome. Oh, I need to stand here, don't I? So I don't stand in front of the screen. So, as Mark said, I'm going to talk a little bit about the MIPS or QPP program and some of the changes for 2019. You get all my technology working right here. First, quick disclaimer. This information is prepared as a general summary. It's not a replacement for statutes or regulations. I encourage you to look at regulations. The other thing I'll tell people about is there's also a listserv for QPP that you can sign up. If you just go to the qpp.cms.gov, there's a listserv, and you can get new information as it comes out. You'll actually get it at the same time that I get it as a consultant. So, quick thing about health-centric advisors, who we are. We have been the Medicare Quality Improvement Organization for the last 5 years for the 6 states of New England. Both Susan, my colleague, who I think maybe some of you know, but was not able to make it here today, and I work in the Brunswick office and focus mostly on the state of Maine. What Health-Centric Advisors does in general is a lot of quality improvement efforts, so working with all kinds of healthcare providers, from physicians to hospitals, about how to design, implement, and sort of track quality initiatives. So what I'm going to talk about today, as I said, is the quality payment program. This is about the Part B rates. And before I get in, I just wanted to kind of get a sense of people's sort of knowledge level. So how many people are familiar with the quality payment program and MIPS reporting, categories and that kind of stuff? So that's mixed. How many are with an organization that is a member of an accountable care organization or participates in a, okay, so there's a few APMs. And then other question I had is, how many of you, the practice has 15 or fewer clinicians? Okay, so there's a few small practices. Very helpful. So what I'm going to go through about the first half of this presentation is going to be about sort of the basic sort of framework of the QPP program and what has changed in 2019. And then I'm going to dive into each of the performance categories and talk about how those have changed. So, as many of you may be aware, 4 performance categories: quality measures, which really have to deal or address sort of at each patient visit, and this would be things like the percentage of patients with a diagnosis of dementia for whom an assessment of cognition assessment is administered. Improvement activities are more at a practice level. That would be things like annual registration in the prescription drug monitoring program, promoting interoperability, which has to do with how much you're using your electronic health records, and then cost, which is looking at both your A and B Medicare expenditures and comparing them to like clinicians, although we can get into a long discussion about how much the adjustments are doing to actually compare you to like. But the intention is to compare you to clinicians that are providing similar services and have a similar level of acuity for patients. For those of you who are not in an ACO, the quality measures are worth about 45% of your score, improvement activities 15%, promoting interoperability 25%, and cost 15%. For those of you who are in an ACO or an APM, the quality measures and the improvement activities are worth a little bit more, and your ACO will be reporting those to CMS for you. Promoting interoperability is also worth a little bit more, 5% more, and you need to report that yourself by going into your QPP portal and filling that out as the year turns over. And then for ACOs, there really isn't a cost category because it's kind of included in the shared savings in the ACO contract. Okay, so the changes for performance year 2019. First of all, the performance threshold has risen to 30 points. And so that's the overall MIPS score out of 100 that you need to earn to avoid any negative adjustment to your Part B Medicare rates in 2021. The exceptional performance threshold is now 75. So if you get above 75, then there's a little bucket of money that can be added onto your rate. If you get above 30, there's sort of a small positive adjustments that are budget neutral. So the positive adjustments, according to statute, can be up to 7%. But as many people probably know, I don't think in the last 2 years, there's not been anyone who's gotten above 2%. And that's because of this budget neutral issue, which is basically there's not enough clinicians who are getting penalized to fund a sufficient positive adjustment to have it be anywhere near 5 or 7%. And then for eligible clinicians in an ACO, will get the score of the overall ACO. So even though you're submitting your PI independently, it gets aggregated and you get one score for MIPS overall. So CMS added a few newly eligible clinician types. It would be physical therapists, occupational therapists, speech and language therapists, which may be relevant to some of your practices, but also audiologists, clinical psychologists, and registered dietitians and nutrition professionals. So the other aspect of MIPS is whether a clinician is eligible. So there's a threshold. If the clinician is below any of these 3 thresholds, then they would be able to, they could be not eligible to participate in the program. And that's billing for more than $90,000 a year in Part B services, providing services to more than 200 Medicare beneficiaries. So more is you would be eligible, or providing more than 200 Part B services. So if you're below any of those thresholds, you do not have to report. However, CMS has added a new component in 19 where you can opt in if you would like to have the possibility of getting that positive adjustment, and you're above any of these 3 thresholds, at least one of them, then you could opt in and participate. Obviously, you're still also taking the risk that if you get below 30 points, you'll get a negative adjustment. You can also volunteer if you just enjoy reporting QPP, or if you expect that you'll be eligible in future years and you want to kind of get a sense of what it is and how you might be performing. And the other thing I want to say is even if an individual clinician does not meet these thresholds, if the group is reporting as a group, then the data for those clinicians, even though they may be billing a very small part of Part B, will need to be reported as part of the overall group reporting. So ineligibility at a clinician level only matters if you're reporting at a clinician level and not at a group level. And then I just talked about volunteering and opting in. The other thing is there's a number of special statuses that a group or a clinician may have that can impact how the scoring goes. These include small practices, so 15 or fewer clinicians. If you're in a rural zip code, if you're in a health professional shortage area, if 75% of your services are performed in an ambulatory surgical center or in a hospital, if 100 or fewer of your Part B encounters are patient-facing, and the new one for this year is if 75% of your services are performed in a facility, which is defined as either an inpatient hospital, on-campus outpatient, or an emergency room, which I suspect does not apply to anyone here, right? Because all the services will be in a SNF, right?
Right.
Yeah, okay. Okay.
SNF is not on there anymore?
SNF does not count as a facility for facility-based.
Well, all the lobbyists.
Yeah. Which is why I tell people to go to the QPP lookup tool, and then you can see what special statuses apply to both the clinician and the group, because what matters, right, is what CMS thinks your status is, not what you think your status is. And if you go to that tool, what you will see is it will list both for the individual clinician. So to use this lookup tool, you have to use an individual clinician's NPI. If you use the group NPI, you will get no information. So use an individual clinician. The site will tell you what that individual special status are. but it will also tell you for the group. I suggest maybe checking 2 or 3 clinicians just to make sure there's no anomalies, but usually it's pretty consistent, and then you can get the group instead of checking all 20 or 100 of your clinicians. So let's talk a little bit about what each of these special statuses sort of does for you. So there's 3 special statuses that automatically exclude you from the promoting interoperability, or the EHR category. And the weight there, so it's 15%, no, it's 25%, sorry, gets shifted over to quality. So then quality would now be 60% of your overall score. And that applies to not patient-facing clinicians and those who are providing 75% or more services in an ambulatory surgical center or on a hospital base. The one tricky thing about this is if you go to the QPP lookup tool and you see that your group is hospital-based, it is hospital-based based on having 75% of your clinicians, not 100% of your clinicians. And for this part of for the reweighting, it has to be 100% of your clinicians. The only thing I can tell you is that you'll have to look up all your clinicians or make sure they all fit the hospital-based. I'm sorry, I misspoke. I'm talking about the non-patient facing. I'm sorry about that. Non-patient facing. You have to sort of look and see if they fit all that. That should be corrected for 2020 reporting year, so I'm happy to say that. But that is a little sort of quirk right now. Another special status is will double your improvement activities. So there are, within the improvement activity, you can get a maximum of 40 points. If you are in a health professional shortage area, rural, or non-patient facing, your score is double. So what does that mean? That means if you do one high value activity and you're in one of these categories, then you're fine. You get your maximum points in improvement activities, or if you do 2 medium. If you were in one of these categories, you'd have to do at least 2 high or some combination of high and medium. To make things a little more complicated, in this instance, non-patient facing is only 75%. So if you're 75% of your clinicians are non-patient facing, you get the double points, you don't get the PI exclusion. And then there's a small practice. And so there's a few things that come with small practice. One is for the quality reporting. As long as you report a measure, you will get a minimum 3 points within the quality category for that, even if you don't meet data completeness requirements for the category. Also, in 2019, you can report through claims. So one of the ways to report out is through your claims. You can only do that if you have 15 or fewer clinicians, which is a change from 2018, as I know some practices are aware. And some practices did sort of get caught in that, is they were able to do claims for 18 and they're not able to do claims for 19. And then the other thing with in quality for a small practice is that there's a bonus that's applied within the quality category. The other 2 things that a small practice gets is that the score will double within improvement activities, and also in promoting interoperability, you can apply for an exemption. So whereas with the non-patient facing and that, you're automatically excluded, here you have to actually submit an application. But the application is very simple. I do not know of anyone having challenges with the application being denied. As of last week, I forgot to check this morning, but as of last week, they had yet to post that application for 2019. But we're going to keep our eyes out and tell people when that does get posted. And as I said, it's a pretty simple process.
When do you expect it to?
I expected it to 2 months ago. So I kind of expect any hour now. The other thing with the small practice, as I mentioned, is there's a bonus, and this will be added within the quality performance category. So in 18, it got added at the MIPS overall level. Now it's getting added within the category. What does that mean? That means although you see 6 points here, that 6 points then times the weight of quality. So if you were just sort of the kind of baseline weighting between the categories, the 6 points in quality would essentially translate into 4.5 points for your overall MIPS. So it's just a good thing to be aware of, because as people are probably aware, numbers get a little crazy rather quickly. The other thing that's new this year is facility-based, and I think as we determined, it won't apply to anyone here, so I won't go into that. But if you have any, good friends in business who do have hospital and are curious if they could have their clinicians take the hospital value-based purchasing score, certainly encourage them to reach out to us. And then there's the complex patient bonus, which adds 5 points to your overall MIPS score. And this is based on really a combination of HCC risk scores to determine if you have particularly acute patients, and then the proportion of the patients that are seen who are dual eligible. So that's sort of seen as a proxy for being a complex patient, sort of bringing in, I think, the social determinants of health. Then the final thing on the overall is the MIPS performance period timeline. It's basically the same as it was in 18. You got this year to report. You got to get all your information in by the end of March. You should be getting feedback in July, which I think that worked this year. I think you got feedback this year or last year. And then the payment adjustment will hit the 2021 claims. So before I dive in to the MIPS categories, if you go ahead, any questions about sort of the overall MIPS program or anything, I'm happy to answer those.
What was the cap adjustments for this year? Is it still 2% or 7%?
Oh yeah, so
last year was less.
Last year, so for 18 performance, it was 5%, and the year before was 3%. And I believe the maximum adjustment anyone got for 17 was 1.96%. And what I've heard, although this might have been updated, the maximum adjustment that anyone got for 18 performance was 1.89. So it actually went down. Even though the cap went up, the maximum went down.
So before all this, we used to get 10% bonus for primary care for geriatrics. Just to give you a perspective.
No, that's helpful to know. And there's been nothing to sort of to offset that. No, it's just straight.
So we're very happy.
Yeah. Okay, so let's dive into the categories. The really big one to change is the promoting interoperability, which is the EHR reporting. If you have any clinicians that are those new clinicians for 2019, so the physical therapist, the occupational therapist, they're automatically excluded from this category. However, if you're reporting as a group, you would still need to include their information. But if you're reporting as individual clinicians, then you would not have to worry about that. So the big changes are promoting interoperability. You need to be using a 2015 version certified electronic records technology, whereas in 18 you could still use the 14 certified. You need to have that in place by essentially 90 days before the end of the year, right? Because in promoting interoperability, you can report for as short a period as 90 days. So as long as it's in place there, and then you can then you'll be fine. The other one of the things that didn't change is there continues to be the hardship and small practice exemption applications, which I talked about a little bit earlier. And then the really big thing is that there's a new scoring methodology. So first of all, security risk analysis used to give you some points. It's still required, but you don't earn any points on it. Most of the measures have remained the same as last year, but how they're scoring has changed. And essentially the change there is, if you recall in 18, If you reported at least one instance of using the EHR for that measure, you got essentially half the possible points for that measure. And then the other half was really based on how prevalent your use of the EHR was. It's now mostly performance. So if you only report one instance of e-prescribing, you'll get 1 point in the e-prescribing measure. And then the rest will be based on your performance. So if you're only reporting one, you're not going to have a very high percentage. So I do expect that that may mean that a lot of practices see their PI scores drop from last year, just for the simple fact that the performance is taking such a greater amount of the scoring. The other thing to mention is that they've created 2 new bonus measures, both of which deal with opioid use, and I'll talk a little bit more about them in a second. So these are the, I'll say new measures, although they'll look very familiar. E-prescribing, I think everyone's pretty clear on what that is. The 2 opioid ones are querying a prescription drug monitoring program and verifying when seeing a patient the opioid treatment agreement. The nice thing about those 2 bonuses is as long as you submit one instance of either of those, you'll get the bonus. So as long as you query the prescription drug monitoring program once, and there's record of it, you'll get those 5 points. So that one, not performance-based, although wouldn't be surprised if in future years it's going to move that way. The other measures are the health information exchange, which includes things that we were very probably familiar with last year, which was sending health information through your EHR, and then receiving health information from other clinicians when there's a transfer or transfer to a new setting into yours. And you also notice that I have some points besides this. These are sort of the maximum points that you can get. So I think an easy example is in e-prescribing. Let's say you do it 90% of the time, then you will get 9 points for e-prescribing. Math gets a slight bit trickier when we talk about the health information exchange. But I can do it in my head. If you did 90 on the health information exchange, because it's worth 20, you get 18 points. So then the other measures are providing patients electronic access. So this is just having the portal that patients can use. You may recall last year there was also a measure about patients using it. That's dropped. That's gone. So what you need to do here is just have the system set up and make sure you're not doing anything that would impede any patient from actually being able to access. And I think it's 3 days of the information has to be up, I think, in 3 days. And then the final measure is participating in a public health or clinical data exchange. You need to do 2 of those to get the 10 points. If you only do 1, you're not going to get the 10 points. In fact, you won't get any points in PI because you will fail this category. However, there are exclusions to these measures. So let me go through those. Oops. I hit the wrong one again. Sit down.
I found it hard to participate in those.
That is, yes. So that is one of the exclusions. Let's see if this can help at all. So for the health information exchange, if during your performance period, so not the whole year unless that's what you choose to be your performance period, if you have 100 or fewer than 100 referrals, you can claim an exclusion from that. Vice versa, or similarly, if you have fewer than 100 referrals going out, then you could claim an exclusion from the sending. So hopefully that helps a lot of people. If you're sending and receiving more than 100, this is a challenge that I know many clinicians across specialties have been having. Our recommendation has often been, if you're part of an ACO, talk with your ACO to see if they can find another clinician or practice in the ACO that you guys can make sure that you're sending information back and forth. And obviously you can do similar outside of an ACO, but it does continue to be a challenge. And I don't see any sign that CMS is going to change it. I think they're very, very committed to this happening in healthcare. The sense I have, and I'd be curious if people disagree with this, is that the real challenge is more the EHR vendors. That there's EHR vendors that aren't setting up things compatible, so then what are you going to do? Or are charging additional fees to actually have this set up. I unfortunately don't have a good answer for that either. But I will tell you, it frustrates me as a former state employee and sort of state employee of Medicaid long-term care programs. It aggravates me that there's vendors that can not meet what is statutorily required of the people they're serving. So.
Yeah. They charge $1,500 per provider per month.
That's crazy. No, it's crazy.
That's 5 years ago.
Mm-hmm.
So imagine PCC would charge you per nurse $1,500.
Yeah. Yeah. Unfortunately, I don't have a good answer to that. And the other thing I want to tell you about the exclusions is with the public health and clinical data exchanges. If you're only able to report to one, then you just need to apply for an exclusion to the second one, and then you'll get your 10 points. If you're not able to participate in any public health or clinical data exchanges, you need to submit 2 exclusions. If you only submit one, you're going to have a problem. And submitting an exclusion, from what I've seen, is as simple as when you go in at the beginning of next year to report your data, there will be a checkbox that says, I have fewer than 100 referrals, or my region does not have access to a registry that I could use. Check that, and then it should automatically do the exclusion. Hopefully I'm not messing up the recording.
I won't talk to you, Judy.
You have to talk to Susan all the time. Should it be on pause?
I think we're good.
All right, sorry.
I think we're good.
So promoting interoperability scoring, I talked a little bit about this earlier. There's maximum points per measure, performance times those maximum points. Submit one record, you'll at least get 1 point. You submit it, right, so if you submitted at least one record on all five measures, and you would get 5 over 100. You would get 1 point. Sorry. Yeah, you get all 5. Oh, I'm sorry. I'm getting a little confused with math. You get a very low score regardless, so I'm not going to try to do the math. You get a very low score. Submit more than 1.
And it's very minimal anyway.
Yeah.
So that's 3 or 4 points.
Yeah. And so I think the sending and receiving is really where that becomes a real challenge. Okay. So were there any other questions about promoting interoperability and the use of EHR? That's really one of the most complicated changes. So cost, it stayed fairly the same. So they still have the 2 sort of major measures. Medicare spending per beneficiary, which is related to any inpatient stays, which I'm assuming doesn't apply to you all because I think it's about inpatient hospital, but you can tell me if you have seen yourself popping up on this. And then the other one is total per capita, which has to do with the primary care physician and attributing basically all of the Medicare costs. So it's really expecting the primary care physician to be the health manager. So those have stayed the same. Weight increased to 15%, and then they added some episode measures, which a few of them might apply to you. So the procedural ones, these first ones, that is if you are the primary clinician for that procedure. So that one I'm suspecting that you guys don't have any clinicians that own that. And then these ones down here, which are the acute primary medical, are if 30% of the eligibility and management, evaluation management inpatient claims are performed by you or your clinicians, which I'm also assuming probably does not apply to you guys. All right, so don't worry about the episode.
And the cost measures, we had talked about this in the office. So they measure the cost per capita for Medicare, and because we're getting the sickest to skilled, So those people that we take care of at scale are the top 10 percentile in the cost. And then we get compared to family practice or generalists. So we're really, in the eye of a quality measure auditor, we're doing horrible because we're costing the system more.
And
Well,
so
that
there's,
was new.
yeah, there are a few, so the proposed 2020 rule came out. We haven't really talked a lot about that because it's a proposed rule and it's hard enough to keep up with like what has actually gone into law. But there are a few things I think that may somewhat help address that. So one is as far as the cost and the application to primary care physicians, it is now, you get attributed cost if you provided an E&M service and then a subsequent service sort of related to that. And they're looking at it sort of as episodes. You will not get attributed any costs that occurred before that E&M. So that's a nice thing.
That would be.
And it will also be risk adjusted on a monthly basis. So if the individual gets sicker, then that will. And the other thing they're talking about doing, I think it'll start in 2022 possibly. It's a pretty big change, so I'm not sure it'll go through. But they're going to start trying to create sort of avenues for different specialties that would combine the cost and the quality and improvement activity all together. So the hope would be that they would have a geriatrics clinic.
Do they know how to spell geriatrics?
I don't know.
But that's good, actually, the part where the hospital stay doesn't count.
Mhm.
That if you prevent the next hospital stay, the cost is going down, then maybe they recognize the geriatric. No, that's
But, no, I was happy when I saw that. There's other things, but that one I was like, oh, that does look good. But again, that's for next year's performance, not this year. There we go. All right, quality measures. Not a lot of changes to this. There's some terminology change. So now you're going to hear the term collection type, which is what are you submitting? Are you submitting claims? Are you submitting through your EHR? Or are you submitting through a registry? There's also submission type, which is how are you actually submitting it? Are you doing it on your claims? Are you logging into the QPP portal? Or are you doing it sort of directly? And then submitter type, which is are you doing it individual, group, or through a registry? I only bring that up in case you see those terms and wonder what do they mean. I see. So the other changes for quality, weight reduced. This is a nice one, which is you can now use multiple collection types. So for example, if you belong to a registry, you can report those registry measures. And then if there's some measures that the registry doesn't have that you're capturing on your EHR, you can also submit those and they'll be aggregated together. So whereas in 18, you were limited, right? Your registry, either doing that or you're doing your EHR. Now you can combine cross measures. So I think that has the potential to make life a little bit easier in giving you some more collection types. Of course, as we giveth, we taketh away. And so now for those of you who may have been a larger practice and were using claims, you can no longer do that. You either need to join a registry or make sure that your EHR is working for you. There are a few new quality measures added. A few of them kind of aged out because they were getting so high because the average performance was, I think, in the high 90s. So CMS said, well, this doesn't really indicate quality if the average person's doing this 95% of the time. Yeah, that's basically the quality. There are a number of measures that if you go to the QPP CMS Gov website and look under, there's a tab there about explore measures. You'll see there's a few different like measure sets. So there's one for geriatrics, which includes all these measures, and all these measures can be reported through claims if you're a small practice, through your EHR or through a registry. I will say it's good to look at specs because the same measure may have different benchmarks based on how it's reported. And then these are measures that you cannot report through claims. They can only be done through EHR or registry. There's also a measure set up there called skilled nursing facility. However, I don't want to give the impression that that means that you can use information that's on the skilled nursing facility Part A claim. It's still about that physician's Part B claim. That's where they're going to get the information. And this is the measures that you could use any of those three. I'm going to mess up the language right now. Submission types. I'm hoping I chose the right one. And then this is a list of the ones that you couldn't use claims on. You either have to do registry or EHR. And we're in the home stretch. Improvement activities. Basically, there's no real changes here. Same as last year. They discontinued a few. They discontinued the ones that had to do with CERT. They modified a few. They added a few. So that's MIPS. Hopefully I didn't throw too much information because I know it's got many levels. I'm happy to answer any questions because I know part of the issue here is how your specific practice works really leads to different questions. And so it really does kind of matter on how these measures impact how you're doing your work, which is why Health-Centric Advisors really stresses doing sort of one-on-one trainings with you and talking with you. We understand there's a lot of variation out there, and we want to work with you on that. You can reach me or you can reach Susan. I will tell you, Susan is a master on understanding claims coding and claim stuff. Not an area that I'm tremendously great at, but I'm working on it. The other thing, just for people to be aware of, is I mentioned that we are the Medicare Quality Improvement Organization. That contract, 5-year contract, actually ended in July. We are in the process. We are in the middle of a transition contract. We will know if we get the renewed contract somewhere between October and November. But one change that will be happening is, whereas under the old contract we were funded to support practices above 15 clinicians or more, that funding will no longer come to us. But we are funded for the smaller ones. That being said, I still encourage people to call us if you have questions. I don't care how large your practice is. We want to make sure that we're supporting you and helping you be able to navigate this system and talk with you about strategies that can improve the way you're doing your work, help you keep your patients healthy and whatnot. But I want people to be aware of that. If you understand why it may take 2 days for us to get back to you rather than a day.
Martha, do you want to mention something about what we submitted to CMS about linking our data to the skilled facility? To be able to use facility data.
Yeah, so I believe Susan sent in, or maybe you had been, I can't remember.
She did.
To encourage, to see if CMS would sort of kind of like this facility-based idea, but begin to bring in what is being reported on the Part A claim as well, because as Dr. Pizzelli has explained to me, on a number of these measures, particularly I think the Falls Assessment and Care Plan is a good example. The nursing home staff are doing the assessment, and then a physician may be coming in and doing the care planning. That physician can't claim it because they aren't actually putting the assessment on their claim, right? Or they aren't doing it, they're doing the care plan. So we have reached out to CMS to try to push them on recognizing just the variation between different practices. I guess when I'm feeling most optimistic, my hope is that when they start to move towards these sort of tracks, that they will begin to incorporate that and begin to be more responsive to these changes. I'm sure I don't have to tell you this, but I know one of the things that I see that is very frustrating for clinicians is there sometimes is this sense of like one size fits all. I know there's a lot of flexibility here, but still, it seems like it's oftentimes the rulemaking is coming from kind of the perspective of what a primary care physician's experience is. So.
Great. Thank you very much.
Thank you.
Thank you, everyone.